I will show you the new concept. uh, thank you, Chairperson. And at the onset, I must thank INSL for giving me this opportunity. As Professor Dilavari has already said, that I am supposed to give you some new concept about managing children with chronic hepatitis B. So what are the issues in children? First and foremost, perennially we are discussing, in India, is it perinatal or horizontal? We acquired hepatitis B through horizontal mode or from the mother baby. Now it has got connotation in the pediatric practice. The vaccination schedule, if you believe it is a vertical, you need to give the first dose vaccination at birth. If you believe it is a horizontal, then you can tag this vaccination with routine vaccination schedule starting at 6 weeks of age. Now see the data. WHO data suggested we are doing very well as far as hepatitis B vaccination is concerned, that 90% coverage of 3-dose vaccine, good. But birth dose vaccine figure is 50%. That means we are still in the dilemma that in India, this is not vertical, probably it is horizontal. That's why we are not stressing that birth dose vaccine. But the reality says that in children, most of these children, we get immune tolerant hepatitis B. So the question is that whether to treat this subset of children or not, immune tolerant hepatitis B. Now if we see the WHO target, by 2030, we are supposed to reduce the mortality from hepatitis, chronic hepatitis B by 65%. That means for the last 2 days, everybody is discussing treat all hepatitis B to reach this figure. So we need to expand the indication, and that includes treating all children of chronic hepatitis B, whether they are immune tolerant or immunoreactive. I'll elaborate on that. So everybody believes that in Asia, almost half of the chronic hepatitis B are perinatal or mother-baby transmission. And we have pediatric study from G.V. Pant Hospital showing majority of chronic hepatitis B in children are actually immune tolerant, because most of the mother are also positive. And this is our SGPGA data to say almost 60% of chronic hepatitis B are immune tolerant and their mother is either present or past hepatitis B positive. Now to substantiate this fact that perinatal transmission is an important mode of transmission in India, we have done this proof of concept study. We have taken 25 mother-baby pair and we have done the genotypic analysis and we have constructed phylogenetic tree. Now what we have shown in Lucknow, in North India, we have 2 types of genotype, genotype A and genotype D, 40 and 60%, and I will see the concordance. Mother-baby concordance is 96%. Most of these baby have the identical genotype of that of mother, and this phylogenetic tree analysis, which has showed that perfect identical homology. The baby and the mother sequence are identical. That means this is the same virus is coming from the mother to the baby. So at least we can say in children in North India, this is a predominant mode of transmission is perinatal transmission. Now the question comes, the treatment part. Should we treat or not? Actually, ideally, you believe that everybody should be treated because you want to reduce the risk of developing HCC, cirrhosis, liver failure. They are body teeming with virus. They are highly infectious. You want to reduce the spread of infection, and obviously the psychological trauma of a growing child is carrying hepatitis B throughout his childhood. But unfortunately, most of the treatment which is available now, they don't respond because their immune system, they don't respond. This is hyper-responsive cytotoxic T lymphocyte, which is responsible for removal of the virus, and this hyper-responsiveness causes the difficulty in getting response with nucleoside analog. However, there are studies to say this is actually T-cell hyper-responsibility related to the virus load. Huge amount of virus. If you can reduce the virus, this very interesting study which has shown, see that huge amount of virus. You put them on the lamivudine. There is a drastic reduction of the viral load here within 4 weeks. And now you see what is happening to cytotoxic T lymphocyte. This is the stimulation with the hepatitis B protein, and these are the absolute number. This is during the period when virus load is very high. They don't have any cytotoxic T lymphocyte function at all. Once you suppress the virus by lamivudine, from the week 28 onwards, this first 24, there is a no antiviral, and next 4 weeks you have given the antiviral, and throughout this period of antiviral therapy, their T cell function has recovered. So this is a concept which has generated a lot of interest. If you can suppress the viral load, probably this hyporesponsive T cell become responsive, and then we can start immune modulator to remove this virus. So with this concept, we did this study in Lucknow. Of course, the same study was done in King's College as well. So first 8 weeks we have given lamivudine, and after that we started added interferon to this regimen. And these are the studies I have quoted in the table. First one is from the King's College, then our study. Our is actually, we have compared with the control arm. This is not randomized. And this is Chinese study, use a different protocol, but ultimately they have combined interferon with LAM. And this is an open label randomized trial. These 3 studies have shown that this functional cure, HBsAg negativity, we got in almost 20 to 22% of the cases. However, this is the 4 studies from US and Canada. They started with 60 patients, ultimately 45 completed with entecavir and PEG interferon. They didn't show this significant response. They showed just 3% HBsAg negative, with this usual figure with other studies. But that is not end of the story. Now what we are talking about the functional care. Why do you need the functional care? Functional cure? Because total cure is impossible. You cannot remove the CCC DNA with the present set of the drugs which we have. But functional cure means when you are achieving HBsAg negativity with undetectable DNA. Because with this functional cure, you can assure there is no progression of the liver disease. There will be reduction, definite reduction of HCC and decompensation, provided this patient is in without any advanced fibrosis. So let's see what the study says. This is a fairly good study, though a retrospective analysis from China, where they have shown the long-term efficacy and safety of pegylated interferon in children with HBe positive chronic hepatitis B. There is 118 children, 2 to 16 years, they have used pegylated interferon, and if you see this data, almost majority are immune tolerant. Their ALT level, 73% cases ALT level less than 2 times. They have very high DNA, and 80% has got mother positivity. So a predominantly immune tolerant group, and they have given the 1-year pegylated interferon. At the end of 52 weeks, see the number, mind-boggling. 48% they have got functional cure, and after stopping therapy over the next 1 year, it sustained. This figure remains as 54%, 98% sustained response of HBsAg negativity. And on analysis, what they have shown, those children who had ALT less than 2, they have a better response than those who have a higher ALT. Further multivariate analysis they show, they have hinted that probably younger patients will respond better. They have taken the body weight less than 25 kilo, the response is better. And obviously whose HBsAg level was low, they have responded better. Now with this idea, they have another study from China. This is published in 2022. They have looked at the response to therapy in the younger children, 1 to 6 years age group. So 236 children, there were 3 different type of regimen used: interferon alone, interferon combined with lamivudine, or LAM alone. So ultimately 144 weeks of therapy they have given, and what they have shown, the combination therapy, when they are using interferon plus lamivudine, at 48 weeks, the response, we are talking about functional cure. We are not talking about E antigen seroconversion. It was just 30%, but this figure become, at the end of 144 weeks, 71%. Now, what they have shown is most important is that HbA1c loss in 1 to 3 years age group. Young means how young? If you start treating 1 to 3 years age group, you are going to get a huge response. 80% of this patient become HbA1c negative. Remember, these are all immunoactive patients. And this figure is just 42% when you are increasing the age towards the 6 years or 7 years of old. So they got the response maximum with combo therapy, lamivudine plus interferon, and when the patient is younger. So this is another study published just recently, April 2024, again from China. And in this study, again almost similar protocol they have used, 372 children. There it is 1 to 6 years. They expanded 1 to 16 years. The whole pediatric spectrum they have treated either with interferon with lamivudine or lamivudine alone, and see again that 1 to 3 years age group. See the response of HbA1c loss in 1 to 3 years age group is 63% functional cure, compared to just 1.6% when you are taking older children, like 12 to 16 years age group, just like adult. HbA1c loss is 1 to 2%. It is 2. So this is the window. Window is the youngest age, and 1 to 3 years is the age where you get the maximum response. So how young is young? We are talking about 1 to 3, 1 to 6, but this is the study again from China. This is actually the real world prospective study. They have taken infant. Infant means less than 12 months. Those infants who are having high DNA with elevated enzyme. So they have two group of infants. One is that 18th infant who their parents agreed, so they have given lamivudine, because the infant, none of the drug is approved. So you need the approval from the parents. Those who are given consent, they started lamivudine. And another 11 where parents said, no, wait for 1 year, then we will go for therapy. So they waited till 1 year, and then they started interferon. If there is no response, no less than 2 log reduction in 3 months, they started lam. Now see the result. So the first group where they started lamivudine during infancy, means less than 12 months of age. So in 3 months of therapy, 40% become age. We are talking about HbA1c loss, again functional cure. And at the end of 12 months, is 83% they become HbA1c negative. Compared to when you are deferring the therapy till 1 year, starting interferon first, and then adding lamivudine after 3 months, then your response is just 36% at the end of 12 months. So, and median duration of therapy. They have stopped therapy after HbA1c become negative, is just 6 months in group 1, where LAM started in early in few months of age, versus you defer by it become 12 months when you delaying it till 1 year, and HbA1c loss at 1 year of age. This is important. You can argue that many of these patients otherwise probably spontaneously clearing the virus. So those 11 children, they have not given any treatment during that infancy. They deferred till 1 year. None of them had got HbA1c clearance when you are not treating. But when you are starting LAM, half of them, 50% are HbA1c clear. So that means this is the effect of the drug. This is not the natural history. So early initiation of antiviral in less than 1 year age group can lead to a rapid and significant loss of HbA1c. Those infant who is having high DNA and elevated ALT. So to conclude, predominant mode of transmission in HBV in children, at least children in India, we believe it is perinatal. And majority of the children, they are having immune tolerant hepatitis B, and it is possible, not only by proof of concept, by different studies, that if you can reduce the viral load, then immunoresponsiveness returns, and then immunomodulatory therapy probably work. But the message which new concept I want to give is that catch them young. There is a window of opportunity. Don't split here whether it is a immune tolerant or it is a immunoactive. Catch them young. 1 to 3 years age group is the group. There we need to treat them, preferably with a combination therapy, to get the maximum functional cure with HbA1c negativity. And this 2024, the Chinese Society of Hepatology and Chinese Society of Infectious Disease, in their prevention and control and treatment of hepatitis B guideline, they have recommended all children between 1 to 7 years should be treated. So we need to take the cue, think about it, catch them young. If you get a child who is falling less than 7 years, don't split here. Dr. Poddar is suggesting immune tolerant, but I believe no, immune tolerant should not be treated. Whether immune active or immune tolerant, treat them as early as possible. Thanks for your patient hearing.
Thank you very much, Dr. Poddar. Anybody has any questions or comments?
So you're saying,
Sir.
you're saying that start lamivudine first, but the other studies were where they didn't start lamivudine first. What was the comparison?
There is a little bit of controversy. The most of us believe that we need to reduce the viral load by lamivudine first, so that what you want to achieve is immunoreactivity. T cell become more active, and then interferon basically is immune modulator.
Yeah.
It enhances the T cell function. So that is the concept. But the Chinese people, they believe they will start with interferon first, and then you add lam. But anyway, they showed a good response.
So there's
So
no
we
difference.
because they didn't give the proper logic
But
why
you
it
have
should
not
be.
done a study with the interferon first and then
Yes,
lamivudine.
yeah.
So this question
Yeah.
is open.
What about Dr. Poddar, excellent lecture. And what about ALT elevation in infants? If it is elevated, anyway, we will get some response. If it is not elevated, then we don't want response. What are their studies suggesting?
This actually, sir, so far only one study in infant, and they have taken only those babies who have been having more than 2 times elevated ALT. There they shown response. So we don't know those babies who are having normal ALT or less than 2 times whether they will respond or not. Firstly, we don't get infant with hepatitis B. That is
Yeah.
the biggest problem.
And how often would you get high LTs in these patients?
Yeah.
That is the question. In the
But Abha, what I want to give the message that we tend to ignore this less than 7 years. We wait, let them earn their treatment. They become 12 years, 13 years, the figure will be just 2%. Whether it is immune tolerant, immune reactive, then so irrespective of their ALT status, if you get a younger patient before they develop immune exhaustion, treat them. You will get a best result.
No, second question is, what is your expert opinion on this issue? Should we give lamivudine first in infants or pack interferon first? So what is your experience from the literature review? What do you suggest to us?
Sir, most of this literature now coming from China, and their protocol, they start with interferon. But rest of the world, like King's College, us, and US study, everybody, all of us have believed that we should give the nucleoside analog, whether it is lamivudine or entecavir, because when we did the study, that time approval was not available. Now you have entecavir, tenofovir, followed by interferon. That makes sense to us. But the other world is showing no, interferon also, starting interferon also works.
Yes, and
any
that question
logic
is
for
not answered.
starting interferon first?
They said no, they in their experience they start and they get a good response, but they didn't discuss that this part, that immunoreactivity of the T cell, that they have not discussed at all.
Closing, we have one more question. Thank you, Dr. Poddar. As usual, I think you raise questions and inspire us also. But I just want to know, why are all the papers coming only from China with such good results? USA didn't give good result. And our own paper, one more, ILBS, they also did not give. So it's again going for confusion. But I realized, like yesterday's talk, if we have to eradicate, we have to treat. Eradication, if you want to do, that's what they were talking about, the Ghana study, I think we have to treat. What do you
Treat
feel? Why
all.
is
Now,
this
but China basic difference is
Is it a
that the
genome?
load of patient, huge amount of patient in China they have, and their policy is more liberal than our. We are restrictive. We just try to stick to a ASLD or ESL guideline and split the here. Does this patient qualify for treatment or not?
But we didn't get good result. Even in that ILBS, we did not get good result. USA paper. But I think we should do. We should give and then see.
Dr. Malti, eradication we can get only by immunization. By Allah.
Yeah, immunization. But
Treatment is secondary.
Let's go to the next talk, yeah.
So we are running late and
No, we are discussing. You clap those 15 minutes.
Mechanism.
Standalone.